Good afternoon, everyone, and welcome to Vienna, and welcome to this symposium. And first of all, I'd like to thank Novartis for organising this important educational event, and hopefully we'll learn lots about MDS today. And today we're going to focus on higher risk MDS. There's lots of things happening in this field, and hopefully today's talks will be stimulating and educational. So my name is Andrew Way from Melbourne, Australia, and I'm joined by great faculty, Stef Meers from the Klina Institute in Antwerp in Belgium, and also by Daniel Wiseman from Manchester, who I presume is a Manchester United City? Tottenham, okay, so that makes no sense whatsoever. So today's agenda is as listed here. I'm going to give a brief introduction on some of the key topics of focus for today's discussion. And then Stef Meers is going to talk about the primary endpoint of MDS, what's important for clinical trials, and obviously what's important for our patients. Then Dr. Wiseman is going to talk about some of the new therapies which are emerging on the horizon in MDS. And then we're going to have a debate about primary endpoints and also about a new algorithm called the IPSS-M, which is creating a lot of interest at the moment with respect to prognosticating MDS. So let's start with the first talk. So this is this the right one? Yep. So these are my disclosures. The main ones also being that I've been a principal investigator on some of the trials which will be discussed today. So I'm going to briefly touch upon 4 topics. Is it MDS? What is the main goal of therapy? When should we consider allogeneic stem cell transplant? And what are just some of the new treatments on the horizon? Now, is it MDS or not may seem a fairly facile question, but as you can see here, this is quite a complex scenario. MDS, like many of the other syndromes listed here, have all been described clinically and by morphologic criteria. And so because of that, you can see that there is a degree of overlap with many other conditions. And so I think knowing does your patient have MDS or not is critical, because obviously if the diagnosis is not correct, then obviously the treatment won't be appropriate. MDS, like AML, is slowly being unravelled and gradually being recategorised by genomic and molecular biology information. And so we know that SF3B1, for instance, is associated with ring sideroblasts, plus or minus JAK2 mutations with respect to thrombocytosis, good prognosis. Deletion 5q in association with hypolobated megakaryocytes, responsiveness to lenalidomide, and more recently, the mutation affecting UBA1, resulting in autoinflammatory syndromes, somatic abnormality, which is X-linked and therefore more commonly found in men, and also associated with dysplasia and some cytopenias and vacuolation. So this VEXAS syndrome could also be categorised potentially as an MDS syndrome in the future. We've also become aware that there are a number of mutations which are listed here, which seem to be common in higher risk MDS as well as AML, and the prognosis is very similar. And so this knowledge is perhaps pushing forward the possibility that there could be the creation of an MDS-AML overlap syndrome defined by more than 10% blasts and the presence of one of these mutations. Furthermore, the explosive growth of next-generation sequencing is even giving physicians the potential to identify clonal pathology even before the formal recognition of a myelodysplastic or other syndrome. And so increasingly, we need to learn how we're going to use this information, whether we even need this information, and what we're going to do with it. And to even take this another step forward, there are even some mutations which are found in patients who have a diagnosis of MDS if we use BLAST criteria, such as NPM1 mutation, where if you have that information, perhaps they should be treated like an AML patient. The reason being, there's some data here you can see on the right from MD Anderson, where the outcomes with intensive chemotherapy for a patient with under 20% blasts, but with the presence of an NPM1 mutation, perhaps looks better than a patient receiving MDS or HMA-based therapy. So increasingly, I think knowing the genetic biology of what we're dealing with will increasingly dictate how diseases are classified and ultimately how they're going to be treated. So we're going to go into a polling question before the next part of the talk, and this question is hopefully very straightforward, just yes or no. In your clinic, over the past 5 years, are you finding that you're recommending more patients for transplant or not? Just use your camera to scan the QR code and try and put in your answers, and whilst you're doing that, I will start the voting. During this period of waiting, I've been told by my daughter not to tell any jokes because she tells me I'm very terrible at doing that. So we have 71% of people suggesting that they are transplanting more frequently. So we'll touch upon that in more detail later, but clearly the questions are, why are we doing that? So let me move on to the next focus point, which is, what is the goal of therapy? I think over the last few years, physicians' aspirations for the goal of therapy has perhaps changed from one which is more supportive or palliative in terms of its intent to perhaps let's try and aim for more. Let's try and give the patient more response and more survival. And why is that? I think that's because of the evolution of potentially more active therapies in the field, which has changed that thinking. And so therefore, categorising the patient into either lower or higher risk MDS becomes critical because that will ultimately determine the treatment. So for higher risk MDS, as opposed to lower risk MDS, where the goal is to optimise the quality of life, I think for higher risk patients, because of the increased propensity to leukemic transformation and shorter survival, the goal is actually to try and change the natural history of the disease. For many years, we've only really had two tools, hypomethylating agents and the big hammer with respect to allogeneic transplant. Most of us have, for many years, now a decade since the publication in 2012, utilised the IPSS-R scoring system to categorise prognosis in MDS. I just wanted to point out one thing, which is this intermediate risk group is a vexing issue because, as you can see here, 20% of patients have this intermediate risk IPSS score. The median survival for this group is 3 years. So obviously, if you're doing a trial and you're looking for a quick endpoint, 3 years is not necessarily going to deliver that easily. Furthermore, there are several patients with intermediate risk MDS that actually don't have an excess number of blasts, and so therefore trying to achieve a remission in someone who already has less than 5% blasts is obviously an issue. Furthermore, you can see here that the outcomes with azacitidine in the intermediate risk group, as I mentioned before, median survival is around 3 years, and there's even some data suggesting or even questioning whether azacitidine does anything with respect to improving outcomes for intermediate risk disease, thereby even raising the ethical question whether patients with intermediate risk disease should even be receiving HMA in the first place. However, like the audience poll, which suggested that more people are doing allografts over the last 5 years, you can see here this is also the case from SEER data from the United States, where the red curve shows the increased numbers of transplants for AML, and the blue curve also showing a very similar increase for allografting in patients with MDS. So with respect to that intermediate risk group, is there more information that we can use to help make that decision? And furthermore, is there more information that we can use to help identify which intermediate risk patients should go onto a clinical trial, for instance? And as you can see here, there are a number of papers which have come out trying to utilise molecular genetics in trying to stratify patients better than traditional IPSS-R scoring. Of most recent interest is this work by Ali Papamanuel, which you can actually go onto the internet at the moment. I think you put in MDS and prognosis and you'll find this IPSS-M score. And you can see here that for patients with very high and high risk, that the median survival is less than 3 years and perhaps identifies a group of patients that would potentially be suitable for active procedures. However, I don't believe we can just use molecular information on its own to make a decision with respect to transplanting, and that traditional clinical parameters should also be present. And this is a really nice paper from Theo de Wit, published in Blood 2017, where in addition to having a patient that's fit, has an available donor, that the patient should have a blast increase, for instance, a dynamic increase of more than 50%, more than 15% blasts in the bone marrow, critical neutropenia or thrombocytopenia or transfusion dependency, in addition to adverse cytogenetic or maybe now molecular risk factors in order to make that decision. Furthermore, another key question is, a patient who does have an indication for transplant and has an excess of blasts, should they receive cytoreductive therapy before the transplant or not? Or should you go straight to transplant without any preceding therapy? Just wanted to alert you to this really nice paper from Uwe Platzbecker's group from the German MDS consortium, whereby patients aged 55 to 70, you can see that there were 162 patients, and the aim was to give 4 cycles of azacitidine before undertaking an allogeneic transplant. You can see that this was successful in 81 out of 162 patients, so 50% of patients went to transplant. However, you can see that with azacitidine alone, 33% of patients dropped off because of progressive disease or death. And also, by the time of the transplant being performed, only 14% of patients actually had CR. And so the key question is, with newer therapies becoming available, can we deliver more patients to transplant in a much better state of disease control, and with that, improve the outcomes and potentially a higher fraction of cures? And so, as you can see here, many therapies, many companies, many organisations are trying to find what is going to be the next big breakthrough in MDS to try and achieve these goals, and Dr. Wiseman will no doubt talk to you in much greater detail about these options. So to summarise, MDS shares many clinical, pathologic and also molecular overlap with many other related conditions, and knowing the diagnosis is the critical first step. Accurate risk stratification, I think, is going to be important for clinical trials and transplant. And lastly, more effective therapies will be needed in order to convert MDS, hopefully from a palliative to a more curable condition. So with that, I'm now going to pass on to the next speaker, who is Professor Meers from Antwerp, who is going to talk to you about complete response in high-risk MDS.
Thank you. Good afternoon. My name is Stef Meers, and I really would like to thank the organizers for giving the opportunity to give this talk. And I hope one of my goals of today is to convince you that beyond complete responses and overall survival, there are other endpoints to consider in our high-risk MDS patients. So these are my disclosures. So we know all that MDS is a very heterogeneous group of hematological disorders. And as a clinician, we guide our treatment decisions based on the IPSS and the revised IPSS, and also on the presence of some mutations. But we know that especially patients with higher risk disease, which Professor Wei alluded to, are the ones that benefit from treatment, because they have, without doing nothing, they have a poor overall survival. And even in 2022, and after ASCO and after EHA, allo transplant still remains the only curative option to deliver to our patients. Unfortunately, only a handful of patients are eligible for this kind of treatments. So the remainder of the patients, and most of all, they are treated with HMA treatments. But there are problems with HMA, especially that not all patients will respond, and the responses are not durable. So we need better treatments. And in part of that, since we treat most patients with a palliative intent, maybe we should think of other endpoints as well. Maybe patients are better off with symptom relief, or with not coming to the hospital more often. This is to show that these are the recent European guidelines. So we see that we haven't changed much in our management the past decade, but we've become better in dissecting those patients that look lower risk from the outside that are not that low risk. But as for treatment possibilities, this has not changed much yet. So I'll go back. So this brings me to the first polling question. I pressed the button too early. So if you think of your high-risk MDS patient, which of the following treatment goals is most desirable for you? Do you want them to survive longer? Do you want to limit side effects? You don't want them to move to your hospital as much as they do now? Do you want to reduce their transfusion need? Or do you want to improve their symptoms? Or all of the above? Yes, I thought so. So I think we all agree that we want all of them, all pieces of them. Oops. So hypomethylating agents are the backbone of our treatments for high-risk MDS. And this was based on the AZA-001 trial, in which azacitidine showed an overall survival benefit over a conventional care regimen choice by the physician. So in Europe, we have azacitidine, and in the US, they also have decitabine and an oral formulation of decitabine approved for the treatment of MDS. But the good results of 24 months overall survival have not been replicated since, neither in registries, national registries, nor in the recent randomized controlled trials. And there's more room for improvement of our treatment because not all patients do respond. And as you've seen in the previous presentation, even in patients that we want to transplant, complete remission is not very often seen with these kind of treatments. Also, the duration of treatment is a problem. And if they fail responding to HMA, the overall survival is dismal. From the patient's perspective, it's also a worrisome treatment because they have to come 7 days a month to the clinic. They have some GI toxicities, and for the patients, it's a forever treatment. They cannot take a break. And in the MDS community, we've tried to combine treatments. And there is a clear rationale for combining treatments, not even in the lab, but also in single-arm studies, we have high response rates. But to date, all combination trials have failed to meet their primary endpoint till now. And what you can see in this table is that with combining treatments, we get deeper responses. But that does not necessarily mean that the duration of the response is longer. So why is that? Why does it always seem that azacitidine kills the other drug and vice versa? So we have to get a step back and think how HMA works. HMA work at very low doses, and they work during the S phase by the depletion of DNMT1. So that means that you have to deliver the drug very often to the patient in order it to work. So if you combine these HMAs with a cytotoxic agent, they'll stop working. The other thing is if you combine it with treatments that give hematotoxicity, you will lower the dose of your HMA or dose delay your cycles, which is not good for the efficacy of the drug. And what we see in clinic very often is that HMAs also destroy normal cells. So in the end, you will end up with a aplastic marrow, and you cannot deliver the drug anymore. What is clear now is that with all these new mutations we discover, and which we incorporate now in our decision making, that doesn't necessarily mean it's getting easier. It's hard to imagine that one treatment will fit all patients. So we have to think about what we want to achieve in our patient. What is the goal of the specific treatment of our specific patient? Do we want to cure him? Do we want to have a deep response in order to get him or her to a transplant? Or do we want other things? Maybe we don't need a complete response in elderly patients that do not proceed to transplant. What can be other meaningful endpoints? Complete remission, event-free survival, PFS, of course, quality of life, or transfusion independence. So that brings me to the other poll question. So if you think of your transplant-ineligible patients, which endpoint do you consider most important in your patient? Is it overall survival, complete remission, transfusion independency, progression or delaying progression to AML, or their quality of life? And now you have to choose between them. And I would, yeah. So no one wants a complete remission. That's nice for my discussion later. You can go home. Oops, no, keep it close voting. So complete remission and marrow complete remission are the preferable outcomes in most trials. But does it make sense? And here's data from a recent retrospective analysis where they looked at all higher risk patients treated with, mostly with HMAs. And they saw that especially a complete response, meaning no blasts and no dysplasia anymore, is the only endpoint that related to overall survival benefits. So the marrow complete response, although the numbers are very small, but also in another cohort, they didn't see any benefit of a marrow complete response. Event-free survival is a composite endpoint that is death from any cause, failure to achieve a CR, or relapse from CR. And the thing is that in the event-free survival is known earlier, so it's a quick pick to see if your drug works or not. And in the latest Panther trial, they used event-free survival as an endpoint, but it failed to meet its primary endpoints. What they did see is that patients receiving 3 or even 6 cycles of the combined treatment, they had an increased overall survival with the combination. So event-free survival doesn't necessarily get all the information we need. Progression-free survival then. So the FDA and the regulators take progression-free survival as a valuable endpoint for approval consideration. And also in MDS, there's a clear correlation between overall survival and progression-free survival. So maybe we should use PFS as a surrogate endpoint. It's an open question. Delaying AML progression. So in the US, decitabine is approved, and this was partly based on the fact that decitabine was able to delay AML progression. On the other hand, we all have patients that progress from 18% of blasts to 21% of blasts. That doesn't mean there's a different behavior of that patient, but if you're using the criteria, these patients progress to AML and are therefore non-responders. And of course, we should not focus solely on hard endpoints, but we should also focus on the well-being of the patients. So, of course, safety is important, and if you use a combination of drugs that is more powerful and delivers more complete remission, you will get inevitably more hematotoxicity. And probably that's the good thing about the combinations of HMA with the monoclonal antibodies. The antibodies seem to be safe to use. We all know as hematologists how many hours our patients stay in the daycare clinic to get their transfusion. And of course, that might also be a good endpoint for us, for our treatments, not to lower the amount of blood that the patients need, not to get rid of the iron overload, but for their time management, because you know it's, in most patients, not a curative disease. So the last thing you want is them to spend in hospital all good days they have. So does a complete response relate to an increased quality of life? We don't know. And the good thing is that we're now measuring these things. So in the end, we will know what's the preferred outcome of the patient. When do they feel better? Is it with a less intensive regimen or a very intensive regimen that will clear their bone marrow? So to summarize, I hope we know that HMAs are the current standard, but it's because we don't have anything better yet. And with the new combination, we can see that we can improve our CR rate, but that doesn't necessarily lead to longer responses. So in order to get new drugs approved, we should rethink the endpoints for specific patients. Maybe a complete remission or overall survival is not the best endpoint for every patient we treat. So therefore, I hope you rethink together as a community all the endpoints we will use in the future to get new treatments for our patients. Thank you. And I now invite Dr. Wiseman from Manchester to discuss all these new treatment approaches in high-risk MDS.
Okay, thank you for the introduction, and good afternoon, everybody. And thanks to Novartis for inviting me to speak. I'm going to talk a little bit about some of the personalized approaches to treating higher risk MDS with some of the novel combinations available to us. Now, why is this not working? Here are my disclosures. Use the mouse, okay. So, we've heard a bit about azacitidine, and I'm going to spend 20 minutes talking to you about a lot of drugs that we're trying to improve upon azacitidine. But I think it's worth starting with just a bit of a plug for azacitidine. It gets quite a bad reputation. A lot of my myeloma and CLL colleagues sometimes give it short thrift, really. But it's easy to forget what a difference it's made to higher risk MDS treatment, and it remains the biggest advance for these patients in the past 2 decades. But it's clear that, for a lot of patients it doesn't work. For many it doesn't work as well as it should, and there's a real need to improve upon its limited efficacy and the limited response rates and duration of responses. In recent years, advances in next generation sequencing, single cell approaches, better modeling of the disease and the microenvironment have really resolved and refined our understanding of MDS pathogenesis. And it's given us a whole load of rational new genes and pathways and other targets for potential new and personalized therapeutic approaches. And I'm going to go on a whistle-stop tour through some of these, necessarily going to be quite quick. I'm going to go through venetoclax, pevonedistat. We're going to go through some of the mutation-targeting drugs that have been tested. and then spend the last section of the talk talking about modulating the immune landscape. And one more important point about azacitidine, which you'll notice seems to be the combination partner for all of these combination strategies. And whilst this is partly convenience and pragmatism, HMA is the standard of care, sets the benchmark, could be very difficult to exclude from frontline therapies. The nature of HMA therapy, altering gene expression on a genome-wide scale, not just due to altering methylation, due to many other mechanisms probably too. It does present all sorts of opportunities to introduce synergies with other drugs targeting more specific pathways. So as such, it is a logical combination partner, and I think all of the studies I'm going to talk about involve AZA plus the investigational medicinal product. We're going to start with venetoclax, which arguably is the most prominent other drug in myeloid malignancy at the moment. Venetoclax, as I'm sure you all know, is a small molecule BH3 mimetic. It acts as an inhibitor of the anti-apoptotic BCL2 protein, which is overexpressed in many cancers and has shown clinical activity, particularly in CLL, but a range of other blood cancers too, including myeloid malignancies. But the expression of BCL2 is variable in MDS and AML, and actually single-agent sensitivity in vitro is only seen in about 30% of AML samples or AML cell lines. And so as single-agent monotherapy, it has limited efficacy. But as I touched upon before, there are now several studies showing why and how azacitidine primes AML and MDS cells for venetoclax mediated apoptosis. Here's one study which shows that azacitidine induces the pro-apoptotic NOXA and PUMA proteins, which primes for venetoclax killing the cells when given alongside. And of course, we know about Ven-Aza. It's very prominent in the AML world. The Viali-A study, one of the most prominent and exciting recent randomized trials in AML, in the older and unfit for intensive chemotherapy group. This study met its primary survival endpoint with an increase in survival from 9.6 to 14.7 months. In the AML sphere, this was quite an impressive response, with a substantial improvement in CR rate and time to CR, with almost half of patients, as opposed to 7.6%, being in CR after a single cycle of treatment. And as we know, Ven-Aza is now the new standard of care for elderly AML, but at a cost. And the toxicity of Ven-Aza, and I'm sure we've all seen this in our patients, is substantially higher than for azacitidine alone, particularly the hematological toxicity, which does make delivery at all, but certainly delivery on schedule, quite challenging for patients. And that is particularly for those AML patients who've progressed from MDS or who have a dysplastic background. So I don't think it's right to assume that we can extrapolate these AML data to the MDS setting. We are now starting to get specific MDS data for this combination. Here's one large retrospective study, so bear that in mind. It's retrospective data. Looked at over 1,000 patients and compared those who received upfront HMA on its own versus those who, by whatever route, managed to get HMA with venetoclax combination as first-line therapy. And despite the caveats I've mentioned, there was suggestion of a clear advantage in terms of CR rate, also in terms of marrow CR rate, overall response rate significantly higher, 77% versus 40% for HMA alone. Some poor risk mutation groups, there was a hint, might do particularly well, ASXL1, TP53. In this retrospective study, there was no survival advantage, but still, quite encouraging suggestion that this may be an improvement. And just a note to say that of those who were relapsed refractory high-risk MDS, most of whom had had HMA before, there was a response rate of 61%, suggesting that the addition of venetoclax can recapture response in these patients. Of course, what we need is prospective data, and so this is a phase 1b study that's been presented at ASH in abstract form, showing a similar CR rate of 35%. This is obviously a single-arm phase 1b study, so these results need to be taken with caution. But the CR rate, the overall response rate, the time to response do seem to be better than would be expected for HMA monotherapy. And we're seeing also an improvement in, or reduction in, the variant allele frequencies really across pretty much all of the mutations that are common in MDS groups. So there's a lot of encouragement that venAza may be a useful combination in high-risk MDS. But I mentioned about toxicity, and I think this is going to be a really big problem, and it may even be limiting for this option. The neutropenia, particularly, and febrile neutropenia, is quite significant. There were adverse events leading to death in 9% of these patients, which I think suggests we need some caution. And actually, the venetoclax, classically given for 28 days in AML, was routinely dropped to 14 days after the first phase of this trial, and that's how the trial has proceeded. So I suspect if it does have a role, it's going to be in a more dose-attenuated and limited fashion than in AML. And hopefully the phase 3 Verona trial, which is ongoing, comparing in a randomized fashion large numbers of patients with primary endpoints of CR and survival, should answer some of these questions. So my first polling question is more of a quiz question. Which of these drugs did not meet its primary efficacy endpoint of event-free survival in a recent phase 3 study? If we can start voting now. Okay, very good, very good. Okay, so most of you went for B, pevonedistat, which is correct. What is pevonedistat? So it's a small molecule inhibitor of the NED-D8 activating enzyme, or NAE, which has effects on the ubiquitination pathway. NED-D8 is a ubiquitin-like protein. It's modified and activated in a similar fashion to ubiquitination, with both processes interacting and coordinating to modify, shuttle, and degrade proteins through the proteasome. And by inhibiting NAE, the normal activation of the key ligase CRL is downregulated, which interferes with degradation by the proteasome, and you have resulting effects on cell cycle, apoptosis, and DNA replication. It's shown preclinical synergy with azacitidine, and the results from a randomized proof of concept phase 2 were very encouraging, demonstrated clinical efficacy for patients with higher risk MDS. However, the phase 3 trial, very disappointingly, didn't meet its primary endpoint of event-free survival. If we look just at the higher risk MDS patients, you can see 19.2 months versus 15.6, which was not significant. And I think I'd say it's unclear what the future for pevonedistat in this patient group holds. What about targeting mutations? If we think about AML again, and we'll all know that there's been some real breakthroughs really since 2017 with a whole heap of new FDA drug approvals. Some of these targeting specific sort of activating or altered function mutations. If we think about midostaurin and gilteritinib, FLT3 inhibitors, enacetinib, an IDH2 inhibitor, ivosidenib, an IDH1 inhibitor, these are really changing the treatment paradigms in AML. But as you can see, if we look at the mutation frequency in MDS, this isn't going to be expected to make a huge dent in the total MDS patients. These are not common mutations in MDS. So, we've got another question. Which of the following drugs targets mutant TP53? Another quiz question for you. Very good. And again, a majority going for the correct answer of eprenatipop, or as I prefer to call it, APR246. which is the correct answer. So, this is a really interesting drug. It's a prodrug. It converts within cells to the active drug MQ, which binds to p53 protein at 2 cysteine residues, which exist in the DNA binding domain. It stabilizes mutant p53 protein in the normal functional structure and actually restores its conformation even in the presence of harmful, damaging mutations. In fact, I think more than 100 pathogenic mutations have been shown in vitro to be sensitive to this drug. And this is the key step in restoring wild-type TP53 function. Early phase responses for this drug in MDS and AML were extremely exciting. I mean, I remember the first phase 1 data to be presented where all patients had shown a response was extremely exciting for such a bad group of patients. And, there clearly is a response, but as the studies have matured, sorry, this should be a phase 2 study, not phase 3, that presented at ASH last year, there is clearly a response rate that would appear to be better than azacitidine alone, but perhaps not the spectacular responses that we were hoping for, having seen the original phase 1 data. It seems to be well tolerated, and it's working its way through later phase trials at the moment. Of course, ivosidenib and enasidenib I touched upon. These are only going to be relevant to small numbers of true MDS patients, but there are definitely good effects in combination with azacitidine, and comparative studies with and without HMA are ongoing, and there was apparently some quite encouraging data presented just the other day at ASCO for these drugs. What about other targetable mutations? So we've now added the potential to target TP53 to the ones we discussed earlier. There is this story of theoretical vitamin C synergy with hypermethylating agents, and particularly restoring sort of TET2 activity. So there may be a role, and again, this is something that is currently in early phase clinical trials. But if successful, this could be an option for a large number of MDS patients. And similarly, there's a lot of interest in targeting splicing. On the phase 1 data for H3B8800 as monotherapy was a little disappointing, and the future of that program is unclear, but there's other routes to targeting splicing which could give extra treatment options for a large number of patients. And similarly with targeting the RAS pathway, rigosertib has proved a bit disappointing, but there are lots of trials ongoing looking at MEK inhibitors, and I think the next level will be ERK inhibitors, targeting the bottom of that pathway. Again, these are relevant mutations in MDS, and particularly MDS-MPN overlap patients. And of course, we already have inhibitors of JAK and KIT, which again could have a role in future combinations for subgroups of these patients. So I'm just going to spend the last section of the talk switching gears slightly to talk about targeting the immune landscape in higher risk MDS. I haven't got time to go into this slide in any great detail, but we understand a lot now about the ways in which MDS interacts with the immune landscape, with the interaction with myeloid-derived suppressor cells, inflammatory cytokines, inflammasome activation, and there's a lot of interest, particularly in the lower risk MDS space, in targeting the inflammasome particularly. But immune checkpoint blockade is not a new concept. It is one that is really quite interesting in the MDS space. Just to briefly recap, immune checkpoints. These are receptor-ligand interactions that mediate co-stimulatory or inhibitory signals for immune destruction. And some of these pathways are overexpressed in cancer, and I'm sure we're all familiar with the revolutionary changes these have made to some other cancers, like Hodgkin's and melanoma and many others. By promoting destruction of cancer cells by T cells. And of course, they've been tried in MDS and AML, but generally with less success. And that may be due to the genetic simplicity of these diseases as compared with some of these other cancers I've mentioned. Here's just a list of some of the studies with what I would call the sort of conventional or first generation of immune checkpoint targets, many with azacitidine or decitabine. And just to touch on a couple of them very briefly, Pembrolizumab, which is a humanized PD-1 monoclonal antibody. There was a phase 2 reported quite recently from the MD Anderson in combination with azacitidine. A hint of some efficacy here. Again, this is just single arm, but really generally quite disappointing results. And another point to make about this study was that they include intermediate 1 risk patients. This was by the old IPSS system. And actually, if you look at this swimmer plot, most of the responders were intermediate 1 risk, and so wouldn't necessarily be classified as higher risk patients by modern trial standards. And 43% had immune-related adverse events, which I think really do limit the efficacy of this type of immune checkpoint blockade. And as if to stress the point, very recently, just a couple of months ago, there was the publication of the first randomized phase 2 data, the Fusion AML-001 study of darvalumab, a PD-L1 monoclonal antibody, with or without azacitidine. Azacitidine with or without darvalumab, I should say. Azacitidine did induce upregulation of PD-L1 in the granulocytes and the monocytes, suggesting it may, prime for better responses to checkpoint blockade. But interestingly, that wasn't seen in the blasts themselves. And the response rates were no different at all, and it's effectively a negative study. No improvement in survival, no significant improvement in response. But more toxicity, both hematological and immune-mediated. But there is this new generation of immune checkpoint targets that I think are going to be more interesting in the sort of patients we're talking about today. The first I'll mention is magrolimab, which you'll probably have come across. This is a first-in-class monoclonal antibody targeting CD47, which is the major macrophage immune checkpoint and do not eat me signal. It's overexpressed on leukemia stem cells, and its expression level is a prognostic factor. And preclinical evidence suggests that azacitidine potentiates this blockade, but CD47 is ubiquitously expressed, and there's potential for toxicity. And we've certainly seen that. The treatment was generally well tolerated in the early phase studies. No patients had to discontinue, but one side effect to be aware of is this predictable and universal on-target anemia. There are ways of potentially mitigating this, but it can be quite significant. There is some encouraging efficacy with deep responses seen in untreated higher risk MDS patients. 6-month CR rate of 56%, higher than I think you'd perhaps expect for azacitidine monotherapy. And many patients deepened their responses over time. And there was a hint of good efficacy against TP53 disease as well. Interest of time, we'll carry on. And I think the role for magrolimab is going to be established by this phase 3 ENHANCE trial. Recruitment is almost complete. And this is going to, again, primary endpoints of CR and overall survival. There was a clinical hold for studies evaluating magrolimab in combination with azacitidine, but that's now been lifted so that that drug continues its path. If I can just have another couple of minutes, Andrew. So anti-CD70, this is another myeloid-specific checkpoint that's expressed on MDS AML cells. This blocks the interaction between CD70 and CD27. HMAs increase CD70 expression on leukemia stem cells, but also increases soluble CD27 levels. It's been used in phase 1 in AML patients and was well tolerated with impressive CR rates. And it's still continuing its path in the AML setting. But the last I heard about this was that its MDS program has been held and is not currently progressing, so the future of this drug is uncertain. I'm just going to finish with a drug called sabatolimab, which targets TIM3 on immune and leukemic cells. So sabatolimab is a novel immunotherapy. It targets TIM3. It's the first compound with immunomyeloid activity. What does that mean? Well, it's expressed on both the immune cells, like other checkpoint targets, but also on the leukemia stem cells themselves. So there's this potential dual mechanism of action, reactivating the immune system to boost its ability to eliminate leukemia stem cells and blasts, but also directly targeting TIM3 on the leukemia stem cells themselves, and interfering with the interaction with galectin-9 and inhibiting the self-renewal of these leukemia stem cells. Phase 1b of sabatolimab with hypermethylating agents. There are arms with decitabine and with azacitidine. And I think the key points here were how well tolerated and how safe sabatolimab appeared. The toxicity was almost exactly what you'd expect to see with hypomethylating agents when given as monotherapy. There were low rates of sabatolimab dose modification, only 1% dose reduction, 38% dose interruptions due to adverse events, but almost everyone was able to continue. There was only one death due to neutropenic colitis. And I think the key message here really is that the perhaps expected immune-related adverse events were very, very rare indeed. There were no grade 3 or higher immune-related adverse events in MDS patients, no serious late onset related sabatolimab-related events. And in fact, of the 7 MDS patients who had any immune-related adverse event, all achieved remission. And there seems to be a good signal of response rate. Bear in mind, this is very early phase data. Phase 2 data is being analyzed at the moment, and the phase 3 has rapidly completed recruitment, so there's more to come for this drug. But the response rate of 56.9% overall, and the CR rate of around 20% in this bad-to-treat group, this is phase 1 difficult patients, was encouraging, and the duration of response, particularly for those who have achieved CR, was really excellent, 19 months median. So there's a lot of interest in what this drug might be able to do in terms of extending the duration of response for patients with higher risk MDS. So just to finish, to summarize, I've covered quite a lot of ground in quite a short time. The treatment algorithm, I think there's a lot of questions still to be addressed, but if we think about how the treatment algorithm for higher risk MDS looks at the moment, or prior to this latest wave of treatments, I mean, it was pretty much this, I think we'd all agree. There weren't very many options. It was allograft or HMA. And you can make a case that, we're not far off it looking something like this, where, the importance of doing NGS, I think when we do have available mutation-directed therapies, the importance of doing NGS, and we're going to talk a bit about the, the importance of NGS for molecular risk stratification. And there's also prediction algorithms now that are being tested in this space to try and identify the best treatment approaches, and new MRD markers that we haven't had time to discuss today. You can certainly envisage a situation in the future where there'll be a number of combination options that would be guided by NGS and other diagnostic tests, and the possibility to move between combinations as well in a risk-adapted way. And of course, we haven't even started to think about the role for triplets, BiTE, potential for myeloid-directed CAR-T therapies. I think the future of treatment for higher risk MDS is looking quite interesting indeed. So just to summarize, the new insights into MDS pathogenesis and its evolution towards AML have highlighted a number of opportunities for therapeutic modulation. Novel agents targeting mutations, the immune landscape, apoptosis, and other pathways are showing efficacy and, importantly, tolerability when given in combination with HMA. However, there haven't been any recent drug approvals in higher risk MDS, and it's unclear how these will all be incorporated into new treatment algorithms. Future directions, we need new biomarkers, MRD-directed strategies, and other rational combinations beyond HMA, how we sequence these treatments, and whether there's a role for maintenance as well. Thanks very much for listening.
A great tour de force of the therapeutic spectrum in MDS. So there's lots of new therapies, and there's many that you've mentioned, two which have not been successful so far. So surely one of these drugs, or hopefully more, as you say, will become successful through trials and make it through to clinic and enable us to use new therapies for patients with MDS. So for the next section, we're going to do 2 polling debates. For those of you walking out the room, you're going to miss out on the live demonstration of the IPSS-M score, which I'll do for the second part of the polling. And we're going to have a debate first between Dan and Stef with respect to what is the key endpoint for MDS. So we're going to do a poll first to find out what your impression is, allow our speakers to put their case forward, and then to see whether they have influenced your decision in favour of one or the other. So please use your cameras to scan the QR code here and answer which, to you, is the most important primary endpoint for patients with higher risk MDS. All right, so Dan, a bit like Tottenham, you've got a big job ahead of you. I have no idea about soccer, so are they doing well?
Right, well, looks like I've got my work cut out, or the other way of looking at it is I've got a bit of a free hit here, because I'm going to try and make the case for complete remission as the best endpoint for MDS trials. Let's start by just pausing to think about what complete remission is. I mean, we all think of MDS as a cancer, as I think everyone in this room, I'm sure, would agree, especially higher risk MDS. So, you know, surely we should be ambitious and we should be aiming for what's the perfect response, complete response. Granted, it's not always realistic in the real world. Complete remission in MDS clearly doesn't always mean complete eradication. But surely in trial settings, that should be the target. That should be our starting point. And there's a long precedent for durable complete remission being used to support approvals in leukemia, particularly in AML. There's clear evidence in the AML setting that achieving CR is associated with less infection, less bleeding, blood product support. And, you know, granted, higher risk MDS isn't AML, but we all know they exist on a spectrum and the lines between MDS and AML are being blurred. It's quite reasonable that we should be setting similar ambitions for our MDS patients too. And we should be aligning our trial design with AML so that we can avoid this sort of dichotomy of approvals and, you know, between biologically, ostensibly the same diseases. And an important caveat for my argument is when I'm arguing for CR, complete remission, I'm talking about proper CR, as per the IWG definition. Let's review what that means. It's not just reduction in blast count below 5%. It's also, it mandates restoration of normal or near normal blood counts, unlike in AML. So by definition, achieving CR in MDS is also giving you a measure of a meaningful impact on other clinically relevant parameters of infection, bleeding risk, and very likely to also be associated with an improvement in quality of life. But don't just take my word for it. Those of you with long memories will recall a slide presented about half an hour ago by my esteemed opponent here, who really made the case perfectly for complete remission, better than I possibly could. If you remember, there was a very recent, we didn't have this data until recently, but there was this very large retrospective study, more than 1,000 patients, which showed a clear association between depth of response and overall outcome, overall survival. Okay, so the predictive value of marrow CR, which I think we all believe is quite a controversial endpoint, that's a debate for another day, but the survival advantage for those who achieved CR was clear, significant, 21 months versus 14 months for PR and less for other categories of response. And it's a much more practical measure, finally. I'll finish on this, after having, I'm sure, persuaded all of you to change your minds. MDS is still a rare disease. Trials are time-consuming and costly. CR is a quick measure to evaluate. survival endpoints require a much larger study population, longer follow-up. They're affected by crossover of subsequent therapies. Progression-free or leukemia-free survival could be prone to assessment bias, doesn't always represent clinically meaningful responses. So, I come back to saying CR is simple, it's objective, it's associated, we've got the evidence now with survival, and it will lead to quicker drug approvals. So I'd say that's better for everyone, not least the patients. So, yeah. That's my case. Over to you, Stef.
Well, it won't be difficult to persuade the ideas of the audience, which I deeply respect, because so the thing is that an overall survival is the easiest endpoint in history. It's a binary variable, yes or no, and every student, every doctor, even CRO and sponsor can make the difference between yes and no. So that's why they adapted in most cancer trials this as an endpoint, because it's 100% accurate. The other thing is, if you look at a CR, what does it mean? So CR means that on a given moment, some technician, you do a bone marrow, technician or physician counts 500 cells and denominates less than 25 cells of those 500 as a blast cell. And then he should say, well, I see some dysplastic cells, yes or no. In the former case, you call it a marrow CR. If you don't see dysplasia, you call it a CR. Is that scientific? Well, there's literature upon it. They've shown marrow slides to expert hematologists, and the concordance between the results was very awful. So it's subjective, a complete remission. And that's why we shouldn't base all our hopes and our future solely on the basis of a complete remission. And it's on a given time point. We all have patients that are doing well on the 5th cycle of a drug, and then the 6th cycle, just before they need a new bone marrow done, they crash with their platelets or with their neutrophil counts. So that's the case against complete remission. The other thing is that I've shown that the CR doesn't necessarily mean that the survival will prolong in trials. Of course, in a retrospective trial, they've seen that a complete response was the only one improving survival, but then again. So, and the other thing is, CR of study number 1 doesn't necessarily mean the same CR of another trial. So we have to do better than that.
So there's actually a question from the audience which might actually solve both your problems. So the question is, should we use CR as an accelerated endpoint with overall survival required for full approval? What do you think about that, Dan?
Well, obviously CR is the right endpoint, but once we've gone beyond that, I think that's a really excellent idea. I think we do need to be more agile and adaptive. If we're going to bring some of these drugs through to approvals and do it as quickly as possible, I think that's a really excellent idea, and I don't know whether there would be room for such flexibility, but yeah, I mean, I think there should be.
And Stef, the same person in the audience has asked another question, which is, rather than both of us being retired before we get a survival endpoint, what about MRD? Should we be using MRD in MDS as a potential endpoint?
Which MRD are we going to measure? Is it just eradication of a population of blast cells? Are we going to say resolution of all driver mutations, restore the inflammatory state of the bone marrow? So I think all the data that have been shown about AML and the same compounds we use in MDS show that MDS is a is a very different disease in which I can't see how you will get MRD besides transplant.
And Daniel, what about in AML where we use CRH, which is restoration of the platelets to 50 and the neutrophils to 0.5? Should we consider extending CR to also include CRH, which might perhaps accommodate some therapies which are a bit myelosuppressive and obviously making it more difficult to get a true CR before the next cycle starts?
Yeah, I think that's a very good point, because I mentioned in my answer to the debate that, I think CR is about a lot more than just achieving blast clearance, and that's particularly so for MDS. So I think, setting different, paying more attention to the actual level of cytopenia and the restoration of near normal blood counts, I think is a really key point if we are going to be using CR. And so considering CR as not just one single entity, I think that's important to get that resolution, to really understand the potential of all of these new drugs.
And Stef, last question for you. With survival, obviously you say it's a clear endpoint, but with many new therapies coming through, how do we deal with the confounding issues of people being salvaged with potentially survival extending possibilities, which has got nothing to do with the first agent being used?
That's a very good point. I think maybe the time they're on a certain treatment, maybe that could be a debatable solution for all the value of all these new different drugs. But I think that you will see that the more people you get in a CR and get rid of their disease, please note that with azacitidine alone, 20% of patients, there are a lot of patients that don't have a response at all, and we don't bring them to transplant. So I think with all these new drugs, we will see more patients getting into transplant. So it's going to be hard to abstract those two groups.
Thank you. All right, so we're going to move now to the second debate question. And so this one is talking about mutation testing. And so I will just get this one up. Thank you. So if we flip over to the next slide, the question is in relation to a poll question regarding the role of mutation testing in MDS. So is mutation profiling needed for prognostication and treatment selection in high-risk MDS? Don't start the voting just yet, because I did promise that we will do a live IPSS-M calculation. So if you get your phones out and you put in this web address, MDS, don't look at that, MDS-risk-model, you'll get the IPSS-M risk calculator up, and then we can try and do one together so you can actually see what it's about before answering this question, which I think would be useful. So the web address is mds-risk-model.com. So hopefully you'll get the IPSS-M calculator up. Can you all see that? Just put your hands up if you've got it. mds-risk-model.com. Okay, can just see hands just to make sure people have got it? You're struggling? No? Okay, we've got hands, good. So you can see the screen. So put in your bone marrow blasts, let's put in 3%. Hemoglobin, let's put in 9.0. Platelet count, let's put in 80. And neutrophil count, let's put in 0.5. And then you can see there that you can put in the patient's age. So let's put in a 72-year-old patient. You can also use the slider bar if you wanted to do it manually. And then hopefully that'll allow you to go to the next screen. And on the next screen, you can see you've got the cytogenetic options. So let's put in, you can see the different categories of cytogenetic risk. Let's put in good risk. And then go to the next screen. And this is where you can put in your P53 mutation status. The patient can either have 0, 1 or 2 p53 mutations. Loss of heterozygosity, usually indicated by very high VAF. And then you can put in whatever other mutations the patient has. And so once you've done that, you get this really nice picture which shows you the risk of the particular patient and the projected outcomes in terms of survival, etc. So hopefully some of you will find that useful in clinical practice to try and augment your assessment of the patient using patient-specific data. So based upon that, let's now answer this polling question. Is mutational profiling needed for prognostication and treatment selection in higher risk MDS? Let's start the voting for that. And whilst we do the next debate, please feel free to put in Q&A questions into the system so we can address those at the end, and hopefully we can try and answer. This time, the case is looking a bit easier for you, Dan, compared to the last one. So take it away, the case for mutational profiling in treatment selection.
If the last one was a bit of a free hit, this is more of an open goal, I think. So hopefully I won't mess it up. I think the answer to this is obvious, isn't it? More information is always going to be better. I'm a big believer in the IPSS-M and mutation profiling in general. I think that these NGS studies, they've revolutionized our understanding of the disease. Think where we were 15 years ago. We now can understand conceptually, right from disease initiation, the interface with clonal hematopoiesis. We can understand the biological processes that are actually happening that mediate transformation. These mutations are giving us a window into the biology and the heterogeneity that we see in practice. The story of each patient's MDS is written in their genes, so why wouldn't we use it? One answer for why not might be practicality and logistics. I think until a few years ago, it wasn't widely available, but that's generally, I think, not true anymore. Just a show of hands, who has easy access in this room to targeted NGS for a higher risk MDS patient if they want to do it? Okay, so not everyone, but a significant majority. And these things are only going to get cheaper. In fact, the debate is moving on more towards whether we should be doing deeper and more whole genome sequencing at the patient interface. So I think it's easy enough for most people in developing countries, at least, to get this information, so we should definitely be using it. We've seen improved discrimination across leukemia-free survival, overall survival, leukemic transformation as compared with IPSS-R. 6 categories instead of 5 is always going to helpfully refine patients. And one of the things that struck me about the IPSS-M is how many patients were redistributed to other categories. If you just look at the really difficult intermediate risk group, it's been touched upon earlier today. It's often difficult to know what to do with those patients. And if you look at where those patients, there were over 500 of them in the study, where they ended up in the molecular IPSS, a remarkable spread, almost, apart from the very lowest risk category. The other 5 categories each had a similar number of patients from that old intermediate risk group. So really giving extra information to help decide which side of the fence to come down on often. And we can all think of patients who were maybe poorly served by the IPSS or IPSS-R. Think of, for example, the deeply thrombocytopenic patient needing platelet transfusions, but who comes out as lower risk, and so in the UK, for example, not eligible for HMA therapy. One salutary tale from my own practice was very recently a patient who I diagnosed with low risk according to the IPSS-R and counselled them along the lines of 5 years plus median survival, very low risk of AML transformation. Well, they transformed to AML the next time I saw them 6 weeks later. Now, obviously, that happens, but the IPSS-M, that patient had an SRSF2 and an IDH2 mutation together, arguably it was predictable that that patient's course was going to be different to how I counselled them. So in summary, more information is always good. I think mutations tell us a lot about what the disease is going to do, and I think now that it's widely available, I think it's a no-brainer. Over to you.
Well, I'm going to use my brains anyway. I say no. I'm a big fan of molecular profiling, so I do it myself in my hospital. It helps me getting my diagnosis right. Sometimes it's difficult from other MPNs to get the diagnosis right. It helps me figuring out which lower risk patient at first sight is higher risk. But the thing is, we cannot do anything without it except get them up to transplant. We got no drugs at this point to see to treat them differently. And I think it's going to be a mess in the future. Just figure out you want to set up a trial just for TP53 mutant MDS. How are you going to balance the groups? Are you going to say, well, we have to balance between monoallelic and biallelic? What's the variant allele frequency? How many cytogenetic abnormalities do we put in each group? Not every mutation is the same. So, and the problem is that how many sites does a company has to open just to get one patient in such a trial every year? So before we do this, I think we have to rethink how we're going to put on or make our trials in order. It's just, we know azacitidine is not good enough, but still half of our patients in a trial just get azacitidine alone. So why are we still doing that? Maybe we can go back and calculate IPSS-M and just try to get some big database and use that as a platform just to figure out quickly which patients, which drugs work in some patients. So we will lose not as much time, so we can see more drugs before we get our pension in a couple of decades.
Thanks, Stef. So, Dan, you want to do NGS on everyone, so what's the turnaround time? How long do we have to wait before we can treat the patient, and is it appropriate to wait that amount of time before starting treatment?
Yeah, it's a really good question, and I think this is obviously going to vary. I mean, maybe we're lucky we can get our NGS back within 2 to 3 weeks, pretty much reliably. And I'd say for the majority of higher risk MDS patients, that's quick enough, even a month or so. Increasingly, the same arguments are being made for AML treatment. We do need to know the mutations in AML, and arguably, that's a more urgent situation to commence therapy. So, I think that we do have time to turn these around. Turnaround times are only going to get quicker. So, yeah, I mean, I think that that's not an obstacle to the application of the IPSS-M.
And Stef, so if you're not going to do sequencing, then how will we pick up a patient with, say, an NPM1 mutation or even an IDH mutation for which there's, increasing data that those drugs might be active?
You got me there. So I think NGS in high-risk patients is something else, because you will not pick them up. And the thing is that now in most clinics you get your cytogenetic report later than the NGS report. So this is how fast things go. So, and maybe we should, So in high-risk patients, to be honest, I think you cannot go for that case of FLT3, NPM1, which probably benefits from good old chemotherapy. Maybe these are the ones that we should do it for.
So Dan, I mean, I do agree to some extent with Stef, just doing blanket NGS testing on everyone. How often are we actually going to change our decision? We could do a rapid test panel to identify targetable lesions, digital PCR for IDH, could do capillary electrophoresis for NPM1. So we don't have to resort to NGS all the time. Do you do NGS on every single MDS patient?
controversial perhaps, but my view is, if not everyone, but I think if your patient is being considered for therapy, I think all of the same decisions that we would have conventionally taken for who we would do cytogenetics on, I think those can be applied to NGS. I think that the turnaround times are comparable, the cost is very similar. I think the more of these mutations you start to do as standalone isolated tests, the more the case is made for just going straight to an NGS panel that doesn't take a lot longer and doesn't cost a lot more. So I tend to do at least one NGS panel. I don't think it's something that we should be doing after each cycle of treatment. I think the question about using NGS for MRD is a very open one. But I think in terms of understanding that patient's disease, particularly with the way new targeted therapies are coming, that are going to go well beyond just FLT3 IDH, and with the IPSS-M for prognostication, I think the case for doing it on everyone who would be a candidate for therapy is quite strong.
Okay, so look, we've got 10 minutes left, and so I do want to take some of the audience questions, because there's some good questions on the screen. Also like to invite people to use the microphones to ask questions here in the auditorium. So the first question that I'll read out is a question from Juliana. So Juliana is asking us, what would you do in a patient with 7% blasts? Would you treat it before transplant or not? So presumably this is a transplant-eligible patient. So maybe Dan, then Steph, did you want to address what you would do for that particular patient?
I mean, it's a great question. It's one that I think we all grapple with. It's a very common question that comes up in our MDT. And I don't think there's clear evidence either way. I know that practice varies. I can tell you my practice, I wouldn't be comfortable going into transplant with 7% blasts. If you think about the time that's likely or inevitably going to elapse between knowing about that 7% blast and actually doing the transplant, it's very likely it's going to be more than 7% by that point. So then you've just wasted time when you could have been inducing a remission. I think that there's a lot of disease there to debulk, and yes, there's a risk of toxicity from induction treatment. But I think overall, and this is evidence-free, I can't say this is definitely the right approach, but for me, above 5% blasts, I would be keen to give some debulking induction treatment.
Steph?
I agree, because from an intellectual point of view, you can see the deeper the response is, the better. The other thing, it depends on what your country delivers as a drug, because in my country, if it's 7%, unless you don't have an unfavorable karyotype, we cannot give, for example, azacitidine, and then you have to rethink, I'm going to give intensive chemotherapy, and that depends on the mutations you get. So I think I need more information, but I think the majority of patients I will send for induction treatments, and therefore we need more available trials. At the moment we can put them in a trial, and that's things we have to do.
I'm actually a little bit different. So I actually, if the patient only had 7% blasts and the counts weren't dropping quickly, I would probably just sit tight if the patient was otherwise well, and repeat the bone marrow in about 3 or 4 weeks. Because what I'm looking for there is if the blast count is rising fairly rapidly, then I would elect to treat. I'm not worried about the blast count going above 20% because I've got Ven/Aza to fall back on for AML if that's required. And if the blast count is static at 7% after a month, no drop in blood counts, I probably would take the patient straight to transplant. So just showing the diversity of opinions between different people. So
would you treat it differently if it was 10%?
No, so I probably would get cold feet if it's sort of heading towards 15. But even then, I had a patient not that long ago who had 15% blast, completely well. Blood counts very stable, not transfusion dependent, and she's going to come back to me in 3 weeks to have another blood count. If the counts start dropping, I'll do another bone marrow. So same principle. I want to know, is this an active and dynamically increasing scenario, or is it really just stable? Because I think just blast count alone is not always the arbiter of whether we should do X, Y, or Z.
And I think that extends certainly beyond just questions about pre-transplant chemotherapy. I mean, decisions about starting hypermethylating agents as well, and I think what you're saying is absolutely right. It's quite common to find a patient with 7, 8, 9, 10% blasts, but who's otherwise well. You sit tight, you repeat the bone marrow, and all of a sudden it's 4%. And actually then this patient who you could have legitimately treated with HMA there and then, in my view, if this is a non-curative treatment, they're not going to go for transplant. I don't see a great rush to start that patient on any treatment. I'd keep the best first-line option. There might be new trials coming along. I'd keep that up my sleeve. So, yeah, absolutely. The blast count as a one-off spot measure can be a bit deceptive.
Okay, so some other questions. Does anybody know when the IPSS-M will be published?
I don't. Do you?
Anybody in the audience? No, so we'll just have to keep using the app without the evidence behind it. That's okay. One question from Renaud. P53 mutant MDS have higher CR rates with HMA alone, but their overall survival remains very poor. Does this not speak against the surrogacy of CR? Who wants to take that one? Stef?
We know that HMA works through TP53 independent ways in some, but I think they rapidly come back. So I'm not sure if they have, so they have high CR rates because they work TP53 independently. So that just says that CR and overall survival are two separate things.
Yeah, I'd just say that, I mean, outside the slightly artificial constraints of the debate, I mean, I think not all CRs are the same, and I think you're right, it's a really good point that CP53, we know they can respond really well and seemingly quite deeply. You can get your cytogenetic CRs, but as you say, that they are generally very, very short-lived, very transient. So, you know, I think we need to know more about how much of a surrogate CR actually is. There's this one big study, but, you know, it's taking everyone as one big group, and we know how heterogeneous it is, and I'm sure that the same isn't going to be true for CR in the TP53 context as in many of the other subgroups.
One person's asking us, some commercial NGS panels don't include all the mutations on the IPSS-M, so how are we going to use this app and account for missing data?
I'll take that because I've spoken to Elsa, the first author on the paper, about this very question, and I don't understand the bioinformatics at all, but I believe that has been factored in. One in particular I think that was discussed was it includes KMT2A partial tandem duplications, which I think a lot of us don't get information on routinely. I think all I can say is that it does factor this in. It will only give you, it will factor in what you're putting in and give you something that's relevant out. So you don't need to input something for all of the options available.
All right, so in the last couple of minutes, we might just discuss some treatments. So I'm going to ask both of you, of all the different agents currently being tested, which one excites you the most, and which one do you think has the most potential to change practice and to benefit patients? So Stef, do you want to give us your thoughts?
Can I answer triplets?
Triplets.
So
okay.
I think.
Must be from MD Anderson, are you? No.
So I think an oral treatment would benefit most of our patients that are transplant ineligible. So I'm hoping that Veneza will be a way to move forward in those patients. So you can maybe, but that's counterintuitive, maybe do less days of hypermethylating agents, and you give some more of venetoclax. I think that's for a patient view probably better for them.
Dan?
So I'm going to slightly dodge the question. I think it's probably too early to really start to compare a lot of these drugs. I mean, the phase 3s are not through yet. I think a lot of what we're judging is based on phase 1. data that's most mature, and some of them have had phase 2s. They all seem to have similar response rates. I think sabatolimab is very interesting in terms of the duration of response that seems to be coming through, but I do think it's too early to be making comparative statements, comparing these different treatment combinations. So what I'll say instead is something I'm very interested in, which we haven't really touched upon, is other combinations that don't include HMA treatments. And I think, trying to do this in a rational way to understand the biology of these synergies, but, thinking of ways of giving, say, some of these immune modulating drugs with venetoclax, for example, and other targeted therapies, making therapy as oral as possible, limiting trips to the hospital. I think these are really unexplored, interesting questions that need addressing.
I think if I had a patient and if I could use any drug, I could restrict it to doublets because of the uncertainties of some of the triplets. I'd ask myself, is the patient transplantable or not? And if a patient is transplantable, I'd like to get them there in remission as quickly as possible. And I think, Stef, you mentioned Ven/Aza as a really good option there. 84% response rate, achieved rapidly, but then going on to transplant to avoid the issues of ongoing myelosuppression. If I didn't have a transplant as an option, then I would strongly consider getting the patient into remission with Ven/Aza or Magroaza, and then perhaps going on to an immunomodulatory agent like a TIM3 inhibitor plus Aza. And because that's so much better tolerated, you could deliver that for 2 years without any issues. And if it does do something to the stem cell, which is what it's supposed to do hypothetically, then that could really lengthen and change the natural history, whereas I think 24 cycles of Ven/Aza for anyone with MDS would be quite tough.
It's impossible.
Yeah. So with that, we have hit 12 in Melbourne. I have no idea what time it is here. And I'd just like to thank everyone for joining us today and staying to the end for this symposium on MDS. I wish you all a very successful and engaging EHA and hope to see you all soon. Thank you.